Hi, this is Dr. Schmoe from the Functional Neurology Center and the Brain Health Online Summit. This is our Technologies and TBI mini-series. Today I'm going to be talking about pain, and obviously a lot of the patients that we see in our office here come in with headaches and they have neck pain from whiplash and trauma. And not only do they have pain in the upper extremity, in the head, and in the neck and in the shoulders, but a lot of times people do also have pain in the low back, in the ankles, knees, lower extremity. When you break it down, it's actually pretty simple. I mean, we want to know where our bodies are in space, and if you injure some of the areas in the brain that affect your ability to know where you are, then you're going to start to develop different types of tightness and tonus and posturing of muscles that are going to lead to those muscles being at a different length. And what can happen is that can lead to sensitization of peripheral subcutaneous nerves that are kind of right underneath the skin, and tissues that lead to a nociceptive barrage or pain stimulus. And that information is going to go into the spinal cord. It's going to cross, and then that pain information is going to ascend. And when it gets into the brainstem, it's going to go into the reticular formation, which is basically a group of neurons that are involved with autonomic function and reflexogenic systems. It's also going to ascend and go into the midbrain. So it's going to go into the upper brain stem. And so that's the spinal mesencephalic pathways. And then that is going to activate what's called the periaqueductal gray, which is really a cool area of the brain that basically activates this opioid response, which should help fire down to calm pain down. So on the way up to higher areas in the brain, through the thalamus and up into the cortex, basically the pain information is going to drop off and go to different regions in the brainstem. And it does this for a purpose, and it's going to do it for protective mechanisms, for allowing us to activate our own body's endogenous opioid system of these descending modulatory pain pathways to calm pain down. And then it gets up to the brain, and then that gives you the representation of where actually the pain is. So like, is that pain in the hand? What specific region in the hand? Say if it was in my left side, that's going to cross, it's going to go up the spinal cord on the opposite side, go into the brain, and then hit up my right brain. So those are basically the ascending pathways that go up into the brain. And when that information gets to the brain, it doesn't just go to one region. I mean, there's multiple areas like the cingulate and the amygdala and different limbic regions of the brain that are going to give you autonomic symptoms. So, people with pain can feel anxiety and depression and fatigue and brain fog. So that's one of the things that I see. It isn't usually just you hurt your arm or you whiplash your neck and the information goes up and now you just feel it right here. Like, you can feel it whole body. Like, you know what that feels like. You can whiplash, injure your neck. Next thing you know, like, your gut starts to hurt. There's a lot of overlap in a lot of different regions cortically, and how they connect with different limbic regions, and how those limbic regions talk to different autonomic pathways that lead to autonomic symptoms like nausea. Some people feel dizzy, get anxiety, and this pain really just takes you down. I mean, so what you see is, as your brain takes in painful information, it shuts down your ability to dual task and your ability to think. So one of the things that I always like to check with people is look into, is there any just subcutaneous nerve endings that are right underneath the skin that are sensitized from whiplash or trauma. So one of these areas, if you go right in through here, it's called Erb's Point, and it has different branches. So one of the branches will go across, another branch will go down, kind of like right above the clavicle, supraclavicular. And then there's a branch that will go down and go like right above the scapula, so suprascapular. A lot of patients that we see obviously have like really tight traps, and they have just like this horrific pain that will sometimes refer up into their head. And people are always working here, but it could be coming from right here. We use a product, it's called Prologel, that can basically go in and change the pH in and around these nerve endings and lead to decreased pain activation, basically feeding into the brain. So that's another region that we like to assess here. And then obviously there's different regions in the suboccipital area. You have your greater occipital nerve, you have your lesser occipital nerve, which actually it comes from a little bit lower and then comes up, but then your greater occipital will give you pain that will go up on the back of the head. And if you've ever had occipital neuralgia, you know that it sucks for one. I mean, obviously, you know, people will feel dizzy with it. People will have just like these headaches that will not just go here, but sometimes you'll see them start to creep over and then go like around the TMJ. And there's a lot of referral from different mechanisms from the neck and overlap from the neck with what's going on with head pain. So you can have different referral patterns into the head that are coming from changes that are occurring in your cervical spine. And a lot of times people will have adjustments performed on their cervical spine or muscle work or manual work. And it helps for a little bit of time, but then the tightness or the increased tone in the neck starts to come back. And most likely what's going on is there's something occurring with the brain and how the brain perceives where the neck is in space, or a sensory mismatch between the neck and the eyes and the vestibular system, leading to an increased tone in the neck. And when you have this increased tone in the neck and you have this change in muscle spindle fibers, that changes the feedback into the brain and your brain's perception of how your neck is moving. And based off that information, if you don't know where you are in space, then you're going to start to develop different types of, maybe roll motion or different types of posturing. And again, that posturing puts you in a mechanical disadvantage to activate nociceptive information that goes up into the brain and basically activates all these pain pathways. So that's just one of the mechanisms that we like to think about, is what's going on with some of these subcutaneous nerves, what's going on with the brain's perception of where the neck is in space. Is the neck tight because of another reason? Is there something going on with the vestibular system or the visual system? Are there these mismatches that are occurring that are leading to neck pain? When you injure different regions centrally, like the cerebellum or different nuclei in the brainstem and the vestibular system, then you're going to develop most likely some sort of posturing in the neck to just get all of your systems to line up to talk appropriately for you to get the most information to let you know where your body is in space. And knowing where your body in space is obviously very important, because that information feeds up into the cortex. And then when your brain is doing well, when your frontal lobe is doing well, when your brain is activated, it actually fires down in these descending pathways that go into the brainstem to fire down to actually modulate your pain. So I always tell people, when your brain is doing good, you're going to inhibit pain. When your brain is not doing good, what's going to be happening is you're going to have less inhibition of the pain, and then you'll start to see these pain pathways just start to wind up. And when they wind up, you're going to get autonomic symptoms. You're going to just not, overall, you're just not going to feel good. And when these pain pathways become activated, you become sensitized and your sympathetic system becomes overactivated. And we know, as a part of our sympathetic system, that there's end organs to that sympathetic system, and they're the adrenal glands. So you have the adrenal medulla, and you're going to have epinephrine, norepinephrine that come out of those pathways, out of those glands, and then that can sensitize your whole body to pain. When you have issues that are going on in the brain, it's very common also to have issues with that descending information to the brainstem and how it regulates the gut. So there's silent nociceptors in the gut. They're very old primitive pathways that can become wound up from inflammatory issues that are occurring GI-wise, that can fire up and actually activate these other central pathways, and that can drive these pain pathways too. So you can have a structural component to your pain. You can also have a neurological component to your pain. You can have a metabolic component to your pain. And that metabolic component from GI silent nociceptors are driving and winding up some of these very old primitive pathways that go in and talk to different regions like the amygdala and the cingulate and these different limbic regions. And then that's just going to take your brain down. You're not going to be able to think. You're going to have problems with dual tasking. When your brain's in pain, it makes it really hard to do two things at once. And yeah, you guys know what that feels like. If you can't dual task, can't do two things at once, it just makes life way harder. And that's going to drain your battery, and that's going to lead to fatigue. So that's a little bit of a story about pain. And what we do here in our office is we're going to assess everything that's going on from a neurological standpoint. So we want to look at your walk, we want to look at your gait, we want to look at your balance, we want to look at your visual system, we want to look at your vestibular system, we want to look at multisensory integration of how all these pathways work together. We want to do a detailed structural examination. We want to look at your structure, your posture, your breathing mechanics, your autonomic system, and kind of paint that picture of is your brain doing good or is it not doing good? And what areas neurologically are not functioning appropriately, so we can start addressing the brain and address the structure and look at what's going on with you from a metabolic standpoint. We run labs on a high percentage of our patients to see if there's anything underlying, like anemia or infection or inflammation, increased bacterial load, SIBO. I test for mold. We look for Lyme disease. There's different metabolic based issues that can be occurring that are winding your brain up to basically increase your perception of pain. So by looking at that from a neurological, structural, and a metabolic component, we can start to get a better idea of what's going on. Some of the therapies that we use for pain, we use low-level laser therapy, which can help with inflammation in the periphery. We use different types of electrical stimulation, not only on the body and on the areas that hurt, but we stimulate your muscles in a way that it's going to activate basically these muscles to get better feedback so you know where you are in space to help your motor patterns. Just because you have pain here, say in your shoulder, doesn't mean that you have to address the shoulder. There might be another component that's going on in your whole kinetic chain that might need to be addressed. We might need to improve your gait to help your low back pain. We might need to improve your balance to help your neck pain. We might need to get your eyes to track more effectively to help with your shoulder pain. We might need to work with a vertical deviation of your eyes that might be caused from your vestibular system to actually help a tightness in your lower extremity or your low back, and that could lead to improvements in your pain. There's more to the story than just this area hurts. There's a nociceptive stimulation that's coming in, so we need to address this shoulder or this neck specifically. We need to look at things from a global perspective and do therapies and manual therapy adjustments. We do HVLA adjustments. We also do different types of low force and non-force techniques. We do other modalities like low-level laser adjustments, vestibular rehabilitation, visual rehabilitation, improving your brain cognitively, and try and get everything to integrate together. So hopefully that is some good information that talks about some of the pain pathways, and you can take that information and do with it what you would like. And I know this is going out to patients, but also providers, and I hope that is good. Thank you.